Okay, well, I kind of thought we were going to be in a little kumbaya circle in the lobby, so this has shocked me a little bit. I'm also at the age where I can't see any of you right now, but if I put my glasses on, I won't see any of my notes, so please be patient. My name's Tracy Schulden. I'm Deputy Director of Behavioral Health at Anne Arundel County Department of Health. I thought that was a long title until I heard you all very nicely say your long titles today. I looked over at Rebecca and was like very impressed because I get stuck on mine. I want to thank first the opportunity to have this learning collaborative. I used to run a program in Baltimore City. We were part of the Baltimore buprenorphine initiative. I don't know if any of you have heard of it, but they had a learning collaborative and we used to meet every month. And one thing I loved and learned is that you learn from others. So the opportunity to see how other people are doing things is really a great opportunity because we don't do enough of that. We kind of work in our little clinics and never get out. So thank you. I've learned a lot since I've been here. So I'm just going to do a little timeline for Anne Arundel County. We have had an OTP there since 2012. As you know, we started doing assessments from 2009 to 2010. We did about 450 assessments, made referrals to our clinic. During that time, we only had one individual show up for treatment. So we knew we had to do something different. It took 2 years. We had a very successful and continue to have a successful partnership with the detention centers there in Anne Arundel County. Started the clinic, did very well, added peer support around 2013, and our peer supports have a lot to do with reentry. We also have our overdose response program. I think that was 2014. And again, the detention center, very supportive, allowed us to do the training and give a kit, which they put into the inmates' personal property so that when they left, they actually had a kit instead of a coupon to show for a kit. So that was not something, that was kind of novel. A lot of places weren't doing that. And so since then, we've added different formulations, Vivitrol, and are really excited about the opportunity to add buprenorphine. We've been trying to do that for a while. So I'm going to let Rebecca, who is our program manager and knows the ins and outs of running the program.
Good morning. Good morning. I'm used to the morning because my day usually ends about an hour ago. So good afternoon. My name's Rebecca Trott. I'm the program manager for the Road to Recovery program, which is the Anne Arundel County Department of Health's opioid treatment program. We consist of 2 community clinics, one in the northern end of the county in Glen Burnie, and then one in the southern end of the county in Annapolis, and then we have a fully operational opioid treatment program that operates out of the Ordnance Road Correctional Center in Glen Burnie, which has been operating since 2012. The program consists of, I'm going to say 1.5 nurses, so we have a full-time nurse and a part-time nurse. And then we have 2 full-time counselors, 1 fully staffed, I'll put that caveat out there, and a counseling supervisor, and then is managed by the program direction and our medical director and assistant medical director as well. We operate 7 days a week, so we do daily dosing outside of the Ordnance Road Correctional Center. Right now we are only providing methadone and naltrexone. We have not had inmate on naltrexone in a long time as well, so all of our clients right now are on methadone.
You actually, in the prior presentation, reminded Rebecca to check her expiration on our naltrexone.
Right, I was going to say, it's sitting in our fridge as well. So, and it's a different process, and I'll talk a little bit about that as well. But so we operate out of the Ordnance Road Correctional Center, where we have our OTP. And then we also work closely with the Jennifer Road Detention Center, which is the county's booking facility as well. So all inmates go through the Jennifer Road Detention Center when they are booked. So they are always going to start there for us. So we have to have a close communication with them as well in order to serve their population. So the way that an individual seeks services with us can start in two different ways. If someone is booked at the Jennifer Road Detention Center, they meet with medical, and they are already on methadone in a community clinic. They inform the staff member, who will immediately notify our nurse at the Ordinance Road Correctional Center. And that notification comes with a release of information and comes with information about their home clinic as well. And that's where we immediately start the process with contacting that individual's home clinic and requesting guest dosing orders. That is where our limitation is right now with the Jennifer Road Detention Center, is we are guest dosing all of those inmates there. I kind of think of it like if you're a community clinic and you have one of your clients going to a facility, inpatient facility an hour up the road, and you don't want to deliver medication, maybe a clinic closer will be nice enough to guest dose and deliver for you. It's kind of that same process, but we have that working relationship with them. So we will request the guest dosing, and then our nurse that is in our Ordinance Road facility will deliver doses down to the Jennifer Road Detention Center for those individuals while they are there. We will continue to provide doses there for as long as their guest dosing is for, or until the time in which they are sent up to the Ordinance Road Correctional Center, if that ends up being the pathway for them. We've had a lot of leniency, as many of you probably had over the last 2 years with COVID. A lot more clinics are a lot more willing to provide guest dosing extensions than ever before, which has really helped maintain them in treatment, whereas in the past we've unfortunately had to taper individuals that were not eligible for transfer, so there's been a lot of leniency that we're hoping is able to continue. And then the second pathway is if someone is not on medication. And if they are not on medication, they can request to be on our program once they are at the Ordinance Road Correctional Center. And that starts with them submitting a request through, now they have a kiosk system on each of their units. So they submit the request. Our counselor sees the request within that communication system, does a pre-screen on the individual to gather information, determine their eligibility, and then that information is provided in a treatment review team with our medical director to assess whether or not they're eligible for admission. Some of the things that I think were talked about earlier today also play into the decisions that we make with admission. I think our biggest thing is when someone is pending trial and there's potential that they're going to go to DOC, we're not going to put them through the admission process of starting someone on medication with the potential of them having to go to state and then be very quickly detoxed. So we like to avoid that if we can, and we're mindful of when their release date is, when their trial dates are. And naltrexone, which again, we don't really have that many interested in it, but is the same process. Someone requests to be on the program, and then we go through the process of deciding their eligibility based on history. So the biggest piece for us is what happens when they leave, and we're thinking about that from the day that they get in. So from the moment we start either guest dosing them or from the moment that we admit them, we are asking for where they want to go when they leave. And that list is maintained on a daily basis, and it's sent to all of our staff, it's sent to corrections staff, so we know exactly where they want to go when they are released. We don't always get the luxury of knowing when someone is going to be released. There's anticipated release dates, there's a plan, and then next day it could look different. What typically happens is that each morning our nurse will go into the facility. She checks the internal system that corrections uses to see if someone is still detained. So we have access to the corrections to their system, which they just changed over, and the name of the program is escaping me right now. We have access to that system, and we can see the names of who is actively incarcerated. And if one of our patients has been released, we then begin the process of sending out their last dosing information to the clinic of their choosing. We begin the process of contacting them to confirm where they are going. We don't always get in contact with them right away. They're also told repeatedly when they are admitted that they are always welcome at our 2 community clinics in Annapolis and Glen Burnie. So even if they think they want to go to one clinic and something doesn't happen or they change their mind, they can come to us. They're given our dosing hours so they know exactly where to go. We also send out emails on a daily basis between correctional staff so they're aware of who's dosing each day, where they are in our treatment process. So our staff are aware when someone's maybe pending trial. We also maintain this follow-up list that has all the information of where they're potentially going to go. We have maintained for the last, we're almost done with 2022, for the last 2 years, 100% connection to a community clinic. So every one of our clients has been connected to a community clinic upon release from the center. So I think I hit on everything as much as I can.
I think the only thing I would add about our peer support is that since we don't do buprenorphine in the jail, there are many individuals who don't want to get on methadone. So our peer support has been very successful in working with those individuals while they've been detained and then helping them get linked to those services when they get out in the community.
Okay, well, I'm Tammy Black from Access Carroll. I'm the executive director. I'm also a nurse, so sometimes I get to, actually many times, I get to have my hands on in the direct patient care part, but I've got a really, really, I'll say powerful team of integrated professionals. And we've been working with the Friends Research team for just a year now. Has it been a full year, Stan? I guess it has. Year and a half. Woohoo! So time has flown by. That's COVID, truly, because we opened up a medical respite and all of that, and it was a whirlwind for me. But it's been a good experience. I would hope it would be for the clients. I have a little bit of information about our clinic, and then a little bit of interesting data about our outcomes. So Access Carroll is a 501c3 community clinic. We are homegrown. We're not an FQHC, but we do provide a fully integrated medical, dental, and behavioral health scope of services. We're 17 years old. When we first started out, we were a free clinic back in the day doing primary care for uninsured folks, and we've now evolved to what we are today. We do provide services 7 days a week, and we began doing the detox MAT portion of our care back in 2013. When we did that, there was a lot of things, it was a lot of discovery, because primary care, family medicine, was always our core service line. And so Dr. Ackerman, who's here with us today, he's our medical director for that service, and added onto his certification, a board certification in addictions medicine, to make sure that we're well prepared. Just to give you a little bit of data, to give you a scope of the significance of this population. So despite COVID-19, we were the only clinic who actually stayed physically open to see people in our community, like face-to-face care. Our folks didn't do well with the virtual environment, just saying. But we had that as an option. But we served just under 10,000 individual people, a little over almost 16,000 visits with a provider, and then several thousand care coordination visits, peer recovery specialist visits, things like that. But we only serve approximately on a rolling basis. Like right now today, we're just under 100 MATers. So it's a small number. Of that 10,000 patients, about 5,300 were medical. And then we kind of group our MATers within that service line because of the staff that attends to that service area. So it just kind of gives you an idea of where we are with who we've served and why we've served them. We provide a full service line of level 1, level 2.1 substance use treatment, like counseling, for substance use disorder. We've really suffered this past, 2 years with the retention of behavioral health staff. Medical staff have done pretty well, really, given all things. I've actually really got a pretty good, solid team. But the social worker or the therapy team has really taken a big turn. A lot of them who are with us full-time, by the way, we added our behavioral health service line in 2017, and that was in partnership with our health department. Beautiful partnership there. But a lot of them left the profession on the outpatient clinic side to do their own at-home services virtually and aren't even doing face-to-face care anymore today. So that was kind of a sad thing because we're, again, a very face-to-face organization with our patients. We serve a lot of homeless, a lot of forensic patients as a general rule. And we're that safety net. So we take all comers. We do a lot of like meals for folks, and we do daily showers and all those sort of extra social determinants of health. We do a lot of housing services and things like that. We work with our shelter every single day. That's like a 24/7 operation there. So the level 2.1, level 1 and level 2.1 services are really substance use related, but 80% of our approximately 3,800 behavioral health patient service line being served are co-occurring. So just to put it out there. And by the way, I track a lot of data, love the data, loved the economic presentation, but I will tell you that from a statistical viewpoint, over the last 12 months, we started a behavioral health hotline. We know GBRICS is firing up and doing their thing, but we have a lot of providers in the county who requested a behavioral health hotline. So we started this about 7 months old. It's about 6 months old at this point. A small volume of calls coming in, but guess who's calling in? Mothers. And they're all calling for adult children with mental health. I've only had 2 substance use calls. They're all mental health calls, just to let you know. Anyway, I will say that from our folks from the Friends Research Group, Sandy gave me the data. Sandy's our front office manager, and she works directly with, I guess, whoever is calling in. She schedules folks for the office to do services outpatient. We had 17 people that were kind of, if you want to use the word, referred in, but only 10 actually came to meet with a friend's nurse. And by the way, all 17 but 1, you said, actually were already our existing patient. So they already knew us. So they knew the facility, they knew the team. It was already a trusted site. We're open every day. So I don't think that was a difficult leap for them to come into the office. 7 of those folks are still with the research component today, and 14 of them are still engaged in our services from an integrated care perspective. So I love what you guys were saying. You're very specifically, I think, wired to serve the detention center folks, whereas they're there for us as another part of our population. And so we work very closely with them. Up until this month, we have had 5 years of being the service provider for our drug treatment court. And so we're very familiar and very comfortable with that process of care. And we also have one of our team members who's an in-kind from the health department, a addictions counselor. She's placed full-time at the jail in Carroll County, and she's a part of our team. So I work with all of Vicki's reports. I know all her data, provide her information to the state on a quarterly basis. So I'm very familiar with that grouping of patients that are being served in there as well. All level 2.1 for the most part services. Very small because of COVID, but nonetheless they were getting care. I could say a lot more about our actual program. Because we do a lot more. We provide the dental care. That's a very, very, very busy service line, I will tell you, with our greatest waiting list. So a lot of these folks are looking for that level of care beyond just the detox MAT, and of course primary care. So I guess, is there any questions? I don't know.
If you have any questions, we've been instructed to provide you the instructions to please raise your hand so the mic can come to you.
Okay.
Great information, great work, really important. Question about Road to Recovery and the 2 community OTPs. Do you guys use the same electronic health record?
We do use.
So am I correct in assuming that your Glen Burnie OTP can access the treatment information while that patient was in the detention center?
So I'm the Welligent guru. The electronic medical record is shut down in that okay, so one of the things we did is we actually made some really good progress in Road to Recovery. Road to Recovery used to be manned by different program managers, and so then you had one program doing it one way, the other doing the other, but we're all Anne Arundel County Health Department, and then sometimes we need staff going to other places, and they're like, well, that's not how we do it there, we do it up here. So Rebecca now oversees all 3 clinics. We've made all the policies consistent as possible, except for ORCC. Obviously, we'll have some separate ones. So we have one electronic medical record, but we also have other clinics and other services. And if you are a staff member, you can go in and see it if you are also in that program. Right. But because they share staff, a lot of times they can get it. We can transfer a record really quickly, even on our phones, once we know somebody's there. But our medical provider is the same medical provider at all of our clinics, so they already pretty much know a lot of what's going on. One of the things, I did talk with somebody at SAMHSA, a doctor, and what we're looking at now is the way they've been doing it is when someone leaves ORCC, they are guest dosed to one of our clinics, which is actually the same doctor, the same staff. So do we have to go through that whole thing, or can it just be an automatic admission? Because it is the same agency, Anne Arundel County doing business as North, Anne Arundel County doing business as South, Anne Arundel County business doing.
As a provider with 7 locations, we all operate under the same tax ID number. However,
Yes.
we all operate under separate NPI and separate BHA and SAMHSA and DEA
Yes.
licenses. So when patients move from one community location to another, they really, we require them to go through an admission process at the new location to open a new EHR, because it's a separate
Right, and we would
silo.
still do that.
Yeah.
We actually had a doctor who's a consultant for SAMHSA who said that the physicals may not, like you could automatically open, most likely you can automatically open the case because the physical is coming from the same company, same agency doctor or something. So like they do that at a hospital, like if you're at a hospital and the hospital has an OTP clinic, they do that there. So we're going to get it confirmed. Anybody knows, that would be great. That could be something to learn.
But right now, it's as if
Yeah.
they all operate separately. So if someone's
Exactly.
coming from Ordinance Road and going to our, Glen Burnie location, they are Ordinance Road sends the guest dosing, and then our Glen Burnie is guest dosing them until they are admitted. So it's really, everything's being sent, a new chart needs to, we can transfer because we're using the same record, but new admission start, new intake, everything's new in that sense. And it's a completely also different program and requirements, so they're treated as a new patient. They just have the connection. And that's one thing which is really nice is we have 2 peers that are in Ordinance Road, but then also come to our
To the
community
clinic.
clinics. So they see the same faces, which is also nice, and can have that.
I wanted to mention, too, that at Access Carroll, we don't do any methadone at all. We actually get a large number of requests to get folks want to come off of methadone, but we do, it's the Vivitrol and the Suboxone. And we've had pretty good success, and our providers are really open to whatever harm reduction opportunity we can that might help with that patient with their situation at hand. So there's a lot of
The other-
opportunities there.
And the other thing to add is that Anne Arundel County Health Department, under Rebecca's leadership, oversees our Wellmobile, which is a low-threshold buprenorphine mobile unit that does virtual as well. So anyone coming from the jail, that's one of the linkages that we use often for individuals who are not on buprenorphine and want to get on. They can get on immediately. We can do it the moment that they leave. So that's also really good for continuity and getting them linked. The longer they go, the more we lose them.
Hi, thank you guys so much for all the good work that you're doing. I am so fortunate to live in Carroll County and to be able to refer patients. I was wondering if you could speak a little bit about the Wellness Mobile, and are you taking the buprenorphine directly to patients' homes, or how that?
So we have no medication on the van. It's all prescription and home induction. And so we have a peer and a nurse, and I know I'm speaking for, but it was like my baby that I handed over to her. But so we have a nurse and we have practitioners as well as a peer. And so we do prescription only. We'll pay for the prescriptions until they get linked. If they, we're the health department. The beauty of working in the health department is we also have access to expedite medical assistance applications, right? And if they don't have prescriptions for a while, we can and can't get medical assistance, we can get them into our clinic so they can continue with the medication there, because of course we can use uninsured eligibility or whatever they call it now to get that covered in the clinic. And our peer will call them the next day, see how they're doing. If they're having any kind of hiccup, they can get the nurse on there. We have some really great dedicated staff. They go above and beyond keeping these people connected, getting them to where they need to go. It's, I need wood, because there is a critical shortage of staff. And so I'm going to knock on wood because they are wonderful. It really takes, we've partnered it with our harm reduction services. We're adding syringe services to that so that if individuals aren't, at least we can keep those communications going. But yeah, we're in Annapolis, 2 locations in Annapolis, Shady Side, and in North County. We don't like drive around and like, woo, say what you gotta do.
Except when
That
we're
would
in a
be
parade-
neat.
in the parade.
Except when we're in the parade and we have to navigate out of Annapolis in that big van. That's exciting.
Since you're both participating sites in the clinical study, what insights do you have about the study participants and their willingness to have an injectable medication? That's question 1. And question number 2 is, have you experienced any kind of difficulties with inducting people from no drug to Suboxone to then giving them the injectable Brixadi?
So we have not had to do that yet. You guys have just been coming on site and taking care of that. If they're interested in counseling, we've been allowing our offices to be used, so that has not, we don't have any experience with that yet.
From our viewpoint, we actually have and I should have this piece of data in my head, but I don't. I know it's less than 25 that are in an injectable in our office currently, some of which are from the jail setting into our office from the Friends study. So it's really a mixed situation. As far as like a longitudinal study on those folks over more than like a 6-month period of time, that would be interesting for me to look at. Because I wonder too, like how long are these folks staying on and what is their compliance rate, especially after the folks spoke this morning about their, in PG County, their experiences with folks coming off of Vivitrol, which I get the Vivitrol piece. But the injectable, like the Sublocades, that's been a successful, I think, model for our office. We have a fair number of people who are coming in for that. But the Brixada, we can't provide that yet. So yeah.
Right,
And
I was just asking about the study participants. I know you can't provide it to people outside of the study.
Yeah. No, I think I think that's to the Sublocade.
The Sublocade.
Yeah. We've had folks go right from one injectable to the other, and that's been a successful piece. So.
And as an OTP, I think we're not as, what's the word I'm trying to think of? I mean, once people have gone 30 days on their medication, in an OTP, when you're coming in, it's a little bit more stringent, the rules and regulations, and we have a lot of, when I first started in Anne Arundel County, it's amazing. I worked in Baltimore City 25 years. I can tell you about all the services there. I'm an Anne Arundel County resident. I knew nothing when I came to the county 5 years ago. But 5 years ago, we had one practitioner in the county that did not charge cash, took insurance for people who wanted Suboxone or buprenorphine. One in the whole county. The rest of them were all cash paying. And our health officer at the time was, bent on eliminating these cash doctors, and we were like, the best way to get rid of the cash doctors are to get practitioners to start prescribing buprenorphine, because no one's going to go and pay cash if they have. We now have like 12 to 15 different practitioners who are offering all formulations that are on the market right now. So, and we have great relationships with them because as part of our Wellma bill, we're making these connections to them. So they most likely probably won't continue in our OTP if someone's been along that road as long on the medication. Most likely we'll be connecting them or help connect if we can to a community provider.
I was going to say, we have one patient that's on Vivitrol right now in our OTP. And I think he started at Ordinance Road, and he's been with us for a while now. And I think probably a big piece of that is the relationships that he's established and how comfortable it is for him. So there's a lot of pieces that play into us, but I think we're not the go-to because of how rigid it can be if you're not on methadone. We also have a handful of buprenorphine clients as well. We're not, it's a hard sell, to be quite honest, if I can go get a 30-day, prescription. But for some, and for most of our patients that are on buprenorphine, it's the consistency, it's the schedule that's been the biggest reason that they stay, is that it works for them, and the accountability is a big piece as to why they've stayed.